All right, part two, or part B, or however you want to label it, of the ethical decision-making discussion here. Who makes decisions? Excuse me. Current studies show that on average, only 13%, see I have my name tag on now, so now you know who I am. Only 13% of patients completed an advanced directive. 1 in 8 people complete an advanced directives. Who does complete them? White, middle to upper class individuals with some education, college education. In at least half of all cases, the patient will be unable to participate in decision making at the time choices need to be made. So who makes the decision? Well, family members and other surrogates will be required to make those decisions. And that's when things get challenging. Imagine you if a parent or a significant other were suddenly unable to make a decision and the doctors went to you and said, what should we do? What would you do? What would you do? That's a big decision. If you don't know what the person wants, you have to decide. And what if you decide wrong? So how can we prevent that? Well, some people plan out in advance and they make sure people know around them what they would want to have done. A lot of times the decision makers will ultimately turn to nurses and doctors for guidance. But it'd be much better if the person didn't have to turn to us. If they could just look at a document and say, John wanted this, or Dad wanted that. So what can we do about that? Well, we can encourage more and more people to complete advanced directives. As nurses, we are in a powerful position to teach people to make decisions, to make plans in advance, and then communicate those plans. It doesn't matter if it's on paper if nobody knows about it. Who should know about it? Everybody. Your significant other, your parents, your adult children, your doctor, your lawyer, your minister, anybody you think might be around when a decision has to be made, let them know. Now, federal law says that any provider that receives Medicare or Medicaid must ask all patients if they have an advance directive and document the answer in the chart. That's why you always ask on an admission, do you have advance directives or a living will? They also must provide written material about the policies and procedures under state law. And they must ensure that patients are not discriminated against whether on the basis of whether or not they have an advance directive. So those are things nurses need to know about, because if you're admitting a patient or if the patient's been admitted already, you can always bring it back up and ask them, would you like more information? Would you like us to help you fill out an advance directive? Would you like to help make decisions should you be unable to make a decision? Planning ahead is what will prevent a lot of problems. Now, there are two forms of advance directives. One type of advance directive specifies who will make the decision. Another type will specify the decisions that should be made. Now, for the surrogate, if you want to say, John will make my decisions if I can't make that, you were talking about a durable power of attorney for healthcare. I'm not going to write it all out because it's a lot of words. A durable power of attorney for healthcare is a legal document that when it is activated, that person has all the rights to make the decisions related to healthcare. Now, there are other powers of attorney. You could have a power of attorney over financials, power of attorney over, that's the other big one. So, but if you have a DPOAHC power of attorney for healthcare, you make all the decisions. So a person is comatose, unable to participate, the doctor will go to you and ask you, what should we do? What do you want done? Not necessarily what does the patient want anymore, because the patient no longer is in the position to answer. They want to know, what do you want done? Now, ideally, you will do what the patient wants, but that's ideally. We don't live in an ideal world. Never have, probably never will. So, we have living wills, right? And advance directives. Living wills and advance directives determine the patient's preference for treatment. John can say, no CPR, or no ventilator, or no feeding tube, or whatever. They set up these living wills and advance directives, making decisions in advance. So, which is more important? Which will provide better guarantees for your patient? If you have a durable power of attorney for healthcare, that person has the right and and obligation, not just right, but the obligation to make all decisions. And they can make any decision, as long as it is not, what's the phrase? Medically inappropriate or medically obtuse. There's a phrase, but in general, they can make any decision. Is that in the best interest of the patient? How about a living will or advance directive where they specify exactly how they want to be treated? That way the person knows how they're going to be treated, right? When you have a living will, if the person says, I don't want to go to a nursing home, that guarantees that, right? No, it doesn't. There are some things you can put in a living will that will work. For example, the person says, no CPR, no ventilator. If my heart stops, it stops. That goes in a living will. You can't put in a living will, if I go to a nursing home, I never want mashed potatoes and applesauce because I hate those. That's not realistic. That's not a legitimate request. But here's the kicker. Living wills and advance directives, they're viewed as preferences by the patient. They are not obligatory. They do not have the force of law compelling anyone else to follow them. They are guidelines. Power of attorney over healthcare. If you have a power of attorney over healthcare and completed living will, they can come in conflict. For example, person says, no CPR, no ventilator. If my heart stops, it stops, let me go. That's in the living will. That's a good statement. It's a legal statement. That's their wishes. Now they become unconscious, comatose, non-responsive. The power of attorney for healthcare is now activated. And that person, that family member or whatever, now is complete decision maker. When that person's heart stops, the durable power of attorney, the power of attorney can say, do CPR. That's legal. Because they can override a living will. Because in a living will, if you fill out a living will, you can change it whenever you want. Because it's your decision. That's your autonomy, right? Your right to guide your own future. But if you're no longer able to make your own decisions, you give the decision-making rights to the power of attorney, who then exercises their autonomy, and they can make the decisions as you see fit. So a power of attorney over healthcare does not guarantee the person will get the care they want. Living wills do not guarantee the person will get the care they want. It provides guidelines. This tells people what they want, which hopefully will help people make a decision in that manner. Power of attorney simply guarantees that the person picks the surrogate decision maker. A common example is a husband would designate a wife, or vice versa, or a parent would designate a child to be the power of attorney over health care, presumably because they've discussed the situations and that the surrogate will follow the guidelines, follow the decisions that the patient wants, but there is no guarantees. They are not obligated. And some people kind of get that confused. They think that living wills and advance directives imply guarantees and obligations, and they don't. They're guidelines. They're making the person's wishes known, but they have no force of law behind them. So which is more important? Both. If you have a good power of attorney who understands your living will and advance directives, that's the best of all possible worlds. Just power of attorney, if they don't know what you want, they're going to make their own decisions. Just living will without a power of attorney, anybody could be named your surrogate, including people who may not have your wishes as the same as theirs. Procedural issues for advance directives, any competent adult can complete one. You do not have to lawyer to complete an advance directive. It can be rescinded anytime for any reason. So you can have an advance directive and decide at the last minute, tear it up and say, no, I don't want that. It's very hard to cover all possible scenarios. The more vague they are, the harder it is for people to make decisions, but you'll never be able to specify every possible potential scenario. And you need to make sure with state law who can witness an advance directive. Usually it's not nurses and doctors, but sometimes it is. Now, there is a process for developing and documenting advance directives. Now, these do not just cover life-sustaining or serious treatment decisions, but they can cover all healthcare decision-making. To use antibiotics, to go to a nursing home, to feeding tubes. This is a process. This is what we do. Remember, we talked about process and structures. The process is how we develop it. The living will itself is the structure. Right? Structure are things you can hold. Process is how something is made or created. The product is the actual advance directive. And it's usually going to be in paper, now more and more digital. And again, make sure that everybody who potentially could need to know knows about it. Certainly your doctor, certainly your hospital of choice. Informed consent is powerful. You are giving, you are consenting to the advance directive in the presence of an understanding of what could happen. You can't just sign an advance directive saying don't do whatever. The person needs to understand that if CPR is not done, their heart will not be restarted. If a feeding tube is not given, they will essentially starve. If fluids are stopped, they will become dehydrated and eventually die. So you need to have informed consent, understanding that if this step is taken, this result will happen. Now, can therapies be withheld or withdrawn based on advance directives? Sure. And again, it's best if people understand this in advance. But any therapy can be not given or withdrawn after starting. Some states are specific about what can and can't be withdrawn, but generally any type of treatment can be withheld or stopped, including ventilation, blood transfusions, dialysis, feeding, hydration, can all be withdrawn or withheld. What about when do you go to the advance directive for decision making? Well, there needs to be two conditions. The patient must have lost decision making capacity. So, irreversible dementia, irreversible vegetative state, something of that nature, where they simply cannot participate in decision making. And the patient must be a condition that's specified under state law as terminal, a persistent vegetative state, irreversible coma, or as specified in the advance directive, such as their heart stopped. If their heart stops, that advance directive kicks in that says no CPR, no ventilation. So it must be a threshold condition and something addressed in the living will. Now, what's the difference between brain death and a persistent vegetative state? Is there a difference? Yes. Brain death is exactly what it says. There's absolutely no function in the brain. None. You hook up the EEG and there's just nothing there. A persistent vegetative state has brain activity, but nothing cognitively functional. So they're able to breathe, they have a heartbeat, maybe they have autonomic reflexes, their eyes might react to light. That doesn't mean they're seeing, they're just the light cells are reacting to light. But there's no thought processes, there's no decision making. That's a persistent vegetative state. Terry Schiavo is the classic PVS patient who's being fed on a feeding tube. That's what was keeping her alive. She had no functional brain ability, but she had minimal brain function. Okay, that makes sense? So enough brain function to keep her body working, but not enough brain to actually be participatory. At what point do you stop treatment? Do you withhold treatment in a persistent if a person is in a persistent vegetative state, do you stop treatment? Well, people have been known to come back. Very rare. But it has happened. How about brain death, where there's no function, where they need to be mechanically ventilated, or they have to have a pacemaker on their heart to keep their heart pumping? What about that? How long do you wait before deciding this person is no longer having a life? Or do you? Do you keep them going? If you are a deontological person who believes that all life should be preserved, then a person who has brain death but is being kept alive on a ventilator and an external pacemaker, you keep that person alive because your deontological belief says all life is sacred. So, again, we'll be going back to that concept a lot. Always look at the decision-making capacity. Can they make a decision? Is it now excuse me. Can they make a decision? Is it consistent or does it change constantly? You talk to a person in one hour they tell the doctor no CPR, and then an hour later they tell their family member no, they want CPR, and then a little while later, no, they don't. That leads a person to think maybe they don't have the decision-making capacity. Do they understand the results or outcomes of their decision? They might say, well, I don't want CPR because my heart will start anyway on its own. Not really. If they expect that, maybe they really do want CPR. So it's education. You are always going to be educating your patients and family members. Now, if a person needs to have a surrogate put in place, there is an order of preference. The best of all possible worlds, if you have time, is to go to court and get a court-appointed guardian. But that takes time. And frequently, decisions need to be made quickly. So that might be the best of all possible surrogates, but it's usually not the one that happens. Second level is your durable power of attorney for health care. It's a legal document. The person made that decision. They signed it. The DPOA signed it. That's the next level. And then after that, it gets fuzzy. Usually it's a spouse or adult children or parents, if the parent of an adult patient. And then it gets very sticky. Because suppose they have 3 siblings and they all have a different decision. Who do you listen to? Multiple children. They may have difference of opinions. The law tries to reflect your desire shared by most people to have a moral intimate speak for them when they cannot speak for themselves. So the law tries to listen to somebody who's close to the person. So again, that spouse, the children or parents, those would be considered intimates. They're not going to ask the next door neighbor, although sometimes a next door neighbor might know more than a family member, but that's not where they're going to go. Standards for decision making. There are substituted judgment is where a person, the decision maker, the power of attorney, or the spouse, is going to make the choice that they think the patient would have made based on what they know. That's substituted judgment. Now, that is a good basis for decision making. You're making a decision that you feel to be in your patient's best interest, your loved one's best interest. But if they don't know, if they've never talked, now they have to do what's in the best interest of the person. Not necessarily what the person wants, but in the best interest based on the decision makers. And that's, again, a little iffy. Ethics is a land of gray. There are very few hard and fast right and wrongs. So you need to be comfortable understanding that different things are put into place. Now, if there is nothing written out, if you don't have an advance directive or a living will, which is the best evidence for what the person wants, then you have to go on patient statements. What have they said in the past? What have they said to you? What have they said to others? That's important, especially if it was in a large group, if there was multiple people that heard it. What decisions have they made in the past? Suppose the patient who's now incapacitated at one time made a decision for a family member in a similar situation. Well, you could presume that that is what they would want. So you're looking at relational evidence. So first there's written evidence, living wills, and then verbal evidence, things they've said, and then relational evidence, things they've done in the past. Those are the preferences, the level of preference for making a decision. Written, verbal, relational. Okay, I'm going to stop right now. I'm going to come back again. We're going to be talking about autonomy and standards of best interests for surrogates. We're about halfway done with the lecture, just so to keep you excited.